Welcome to the NEI podcast. In today's episode, we're coming to you from the 2024 NEI Synapse in Las Vegas, Nevada. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hi, everyone. This is Dr. Dani Cabral. I'm a double board certified neurologist and psychiatrist, and I'm an Alzheimer's subspecialist and researcher. I will be answering your questions about my panel presentation, which was called Memories in the Future, an update on the diagnosis and treatment of Alzheimer's disease. The first question I have here is, what is your opinion on neuropsych/diagnostic testing in regards to diagnosing Alzheimer's? I am a huge proponent of neuropsychologic testing, so a formal comprehensive neuropsychological evaluation by a neuropsychologist, which is usually PhD or doctorate in psychology trained professional. They're extremely helpful in that they complete, it's usually a 3 to 4 hour long battery of cognitive tests assessing different domains of cognition, far beyond memory, executive function, language, reasoning, processing speed, motor processing. They are assessing also sensory needs like visual and hearing, and typically do a really great job of putting everything together and give some really comprehensive recommendations. And most also will weigh in on what then the potential etiology or etiologies of the cognitive change are due to. So I absolutely recommend that people have neuropsychologic testing done, and though they're, not found everywhere, neuropsychologists, so that can be a challenge in some areas. All right, next question. How do you diagnose DAT, which I think they mean dementia of the Alzheimer's type, without amyloid PET, since it's not available in all areas? Excellent question. So we'll do I'll just run through quickly the standard clinical approach to the steps to diagnosis and then subsequent diagnostic testing. So of course, first we'll do a comprehensive history taking with the patient, and really important to have a family member or other informant who knows the patient well and can give information about how they've been doing recently. We'll then do a assessment, of course, of typical with evaluations, medications, other medical issues, hear about their social history, their use of any alcohol or drugs, and then smoking, and then we'll do a neurologic exam. Now, the labs that we typically do as a starting point are CBC, comprehensive metabolic panel. We'll do thyroid with TSH and B12. That's usually the lab starting point, and then we'll do imaging with an MRI of the brain, and we can do this without contrast is preferred. And so once all of that is done, it can be clearer that this person looks like they're in the Alzheimer's type. But as mentioned earlier, the comprehensive neuropsychologic testing is very valuable as a next step. Now, when you don't have amyloid PET, if you're looking for the Alzheimer's biomarkers, what else can you do? Really, the one thing is the cerebrospinal fluid panel, the Alzheimer's panel, which can be done through Athena Diagnostics or the Mayo Clinic. So these are specialty CSF studies, and certainly that's where you need to have a trained professional who can do the lumbar puncture. It is very valuable and gives a lot of information. So the results of the Alzheimer's CSF panel, what we see are the amyloid levels and the phosphorylated tau and the total tau. And the total tau is an indicator, is a nonspecific marker of neurodegeneration. And the other results are put onto typically a ratio of amyloid to tau, and that tells us if the sample is consistent with Alzheimer's disease or not consistent. And also, sometimes there's people who fall in the indeterminate ranges, and so that can be challenging also. So I would hope that you have access to getting the lumbar puncture done by someone. The next question is, how important or helpful are neuroprotective agents like vitamin D, COX-2 inhibitors, melatonin, omega-3, and acetylcysteine minocycline, erythropoietin, lithium, even caffeine and nicotine in helping patients in early stages of dementia. So right now, there's nothing that's really showing of those mentioned that they are neuroprotective in the early stages of dementia, nor even things using these earlier in life can we say for certain that they decrease the risk of developing dementia symptoms later. Unfortunately, part of the challenge again is that we don't, until recently, we haven't biologically characterized the cause of the dementia in a person. And so when we're looking at, risk factors or protective factors earlier on, we don't actually know who has Alzheimer's and who doesn't of those who have dementia. So this is changing with our biologic understanding and advances now in biomarker testing. And so this will be helpful to better answer this question. And again, I do put in a plug for, we know that there certainly is a link between aerobic exercise as being neuroprotective for dementia, development of dementia 20 years later. So in midlife, really. The next question is, any thoughts on new Dexta on agitation in dementia? So this is a treatment that continues to be studied and is actively in clinical trial and appears promising. This isn't yet covered by insurance, so it's typically quite expensive. And I've seen it be helpful in some circumstances and not in others, and it's not yet approved. But so that makes it challenging. And I would say I'll look forward to continued positive data from the trials and hope that, it would be great if this drug ends up panning out and gets FDA approved. Next question. Regarding Alzheimer's disease with behavioral disturbance or delirium, with what antipsychotic would you recommend as needed in an acute care setting? I think this is a tough question because, we know that quetiapine has the less risk of side effects in terms of EPS, but it often is not very effective for the agitation or the behavioral disturbance. Other antipsychotics may be more effective to calm the person, but they will often typically come with these EPS symptoms. So I'm reluctant to weigh in on just naming a specific antipsychotic because also we want to keep in mind, I think something important to keep in mind here is that what we've learned is that if we look at the brains of people who have Alzheimer's disease at death, almost half of them also have Lewy body disease changes in their brain. And so we know that Lewy body disease individuals are more prone to the Parkinsonism and related side effects of antipsychotic medications and are going to worsen their maybe already existing motor dysfunction. And so if you're able to, say, look at the person in front of you or that they have some kind of Parkinsonism, to avoid those antipsychotics that are more likely to cause such side effects such as risperidone. But otherwise, it is sort of just throwing the net out. Next question, do you see more benefits from one particular cholinesterase inhibitor for Lewy body disease? For example, is galantamine better than donepezil? So in my clinical practice, I would reach first for donepezil in Lewy body disease, and we don't have data on this to guide this question, but clinically, it seems that they're all pretty similar in terms of their impact, and I and most of my colleagues do start with donepezil for Lewy body disease cognitive changes. Next question, my hospital formulary does not have brexpiprazole. Would you recommend aripiprazole instead for agitation in seniors with Alzheimer's? I think aripiprazole is an option, ziprasidone is an option, quetiapine is an option. Risperidone is an option also. And, interestingly, risperidone is approved for agitation in Alzheimer's disease in Europe, but not in the US. So, and in, I believe, another country, I believe Japan. So that's certainly an option. And again, I would just avoid risperidone if the person has any Parkinsonism already, but that is a good option to try as well. Next question. I work exclusively in consult liaison psych. For acute agitation, we use second-generation antipsychotics. Do you recommend considering concurrently starting an SSRI or stabilizing the acute issue, then starting SSRI for a longer term? How swiftly does donepezil work for auditory and visual hallucinations in Lewy body disease? So 2 separate questions. So starting with for acute agitation in consult liaison psychiatry, I think it's a fabulous idea to concurrently start an SSRI. And, since we know that's going to take a little time to be effective, while also starting an antipsychotic if that is needed, if it's to that degree of agitation. And of course, stepping back, I'm sure you're actively also looking for, what are other possible medical and medication and environmental causes for whatever is causing this acute agitation and addressing those things. And then in terms of the donepezil for hallucinations, I've seen that work within 2 weeks. That can help with lessening those or obliterating them. So it does work pretty quickly, but not immediately. And the last question is, are SSRIs protective against developing dementia? Interestingly, there's been studies that on both sides of this question. There's been studies of that retrospective analyses that show that SSRIs are protective against dementia, and then there's studies that show the opposite, that people on SSRIs have an increased incidence of dementia later. So it's unclear, and I think, obviously a big confounding factor here is that, so what are the reasons the SSRIs are being started? Well, these people have depression, anxiety. So maybe, some of those individuals have that because they actually have Alzheimer's building up in their brain, the Alzheimer's changes, and their first symptoms are neuropsychiatric. So they're going to get started on SSRIs, maybe, say in their 60s, and then they later go on to develop the cognitive changes that go on to progress to dementia. And so it could look like the SSRIs, people who are on SSRIs are more likely to develop dementia because of that confounding factor. And then the flip side being, of course, that behaviorally and psychologically to have one's psychiatric symptoms treated with SSRIs could allow a person to then function better and therefore get out of their house, be less isolated, have more socialization and activity, which will be stimulating to their brain and help build neural pathways, because we know that social isolation is very detrimental to the brain, and especially people who have dementia. So it seems like the jury is still out on that question. That's all the time we have. Thank you for your great questions, and I hope my answers prove useful to your practice. Have a great day.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.